Right, so it's 12 noon Central Time. We're going to start. Welcome, everyone, and thank you for joining today's PT in Mental Health Lunch Bite. I'm Johan, a member of the PT in Mental Health Catalyst Group, and will be serving as your moderator for today. So before we get started, just a few quick reminders. Today's session is being recorded and will be available later on the APTA Leadership Academy of Leadership and Innovation YouTube channel. And if you have questions during this presentation, please submit them using the Q&A feature. We'll do our best to address any as many questions as time allows. So tomorrow you'll receive a hello from Greece. Tomorrow you'll receive a brief follow-up email with a link to a short evaluation survey. We'd really appreciate your feedback as it helps us improve future lunch bites and plan topics that are most valuable to our community. So with that, it's my pleasure to introduce today's session and speaker. Today's session is entitled Not Fragile, Adapted, a Practical Introduction to Trauma-Informed Care. This session will help us think about how trauma-informed care can shape the way we observe, communicate, and respond in PT practice while staying within our role. So we're very excited to welcome Faith Stokes. Faith is a double board certified orthopedic and women's health clinical specialist, a fellow of the American Academy of Orthopedic Manual Physical Therapist, and a certified pelvic rehabilitation practitioner. Her work focuses on integrating psychologically informed care, trauma informed care principles, and lifestyle medicine into physical therapy practice with clear clinical reasoning and appropriate scope. We're grateful to have her with us today. So please join me in welcoming Faith Stokes. Faith, the floor is yours.
Thank you so much. Everyone, I want to welcome you to a very practical approach to trauma-informed care in the clinic. Just briefly looking at our objectives today, we're going to try to identify some signs and symptoms of trauma-informed care, or sorry, trauma patients in the clinic, so without having to ask them. And then how do we use trauma-informed communications and interventions that matches the 6 pillars of trauma-informed care? Be on the lookout for this handout symbol. It's going to indicate that there is additional resources included in the handout. A QR code will be available at the end of the session. So we're going to start with a few brief definitions. When we look at trauma, this is an event or set of circumstances that are experienced as harmful and or threatening that have lasting impacts on well-being. In other words, when a traumatic event happens, when the nervous system has to adapt, oftentimes it remains adapted in these cases. And these adaptations are where trauma-informed care comes into play. We may not be able to change any of these adaptations, but what I would like to argue today is that when we are trying to support healing following a trauma, we want to place this individual in as healing an environment as possible. And that is certainly a role that PT can play. The first thing that I want to dispel, though, is the myth that trauma creates fragility in these systems. When we see nervous system adaptations following a trauma, this is the nervous system doing exactly what it was programmed to do, which was adapt and keep the organism alive. The problem becomes when that nervous system is then not placed in a supportive environment, those adaptations can remain. Some of those adaptations are healthy coping mechanisms. Some of them will end up having negative consequences for the patient, which may lead them to come to therapy for us. So our role in PT is to build capacity for healing while recognizing that the adaptations are present. When I was early in clinical practice, I was taught to screen for trauma pretty regularly in clinical care by asking directly or including it in my paperwork. And what we found is that when we ask an individual to recite often the worst day of their life, that it can destabilize them both physically and emotionally. And this is the equivalent of opening a wound without having a first aid kit present. And so we've moved away from that, encouraging to allow clinicians to try to recognize trauma in the clinic. And we'll talk about those observations today. and allow the patient to talk about it if they would like to. So, I want to begin to introduce to you some of the things we can do to recognize trauma sensitively in the clinic and adapt our care as needed. This is going to start with appropriate screening, both in intake paperwork, our social interactions with the patient, physical behaviors, and our objective exam. But that leads us to our first challenge of the day. Evidence says that in PT, we are still not consistently screening for mental health conditions affecting a patient or yellow flags. And this is going to be a key insight for you recognizing trauma in the clinic without having to ask the patient directly. The reason why is that trauma exposure increases the risk with these mental health disorders and others, but this is a fairly comprehensive list of what we know has a strong overlap. And the effects have a dose response relationship, meaning the larger the trauma or the more frequent the trauma, the more likely it is an individual is going to experience some of these mental health challenges. This dose response is especially important when we consider something like ACEs or adverse childhood events. So, if you're not as familiar with this, these 10 items have been identified as risk factors for long-term physical and mental health consequences, with risk compounding with each additional ACE. So, when we look specifically at mental health issues, each additional ACE is going to increase this individual's risk for a psychiatric disorder by 52%. Sexual abuse is particularly predictive. And the studies that looked at this looked at tens of thousands of twins. And when they controlled for genetic and environmental confounding, this was the data that they found. So, ACEs or adverse childhood events are very closely related to mental health disorders. While a patient may not always be willing to admit or talk about a mental health disorder initially, we can begin to recognize this in their behavior. So, a lot of my ACEs patients will present with these four behaviors. There are certainly others, but I want to highlight these today as I see them the most often. These individuals are often very eager to please us. However, they have an inconsistent performance. What I want to point us back to is the fact that a lot of times these kiddos were very eager to please adult figures in their life to create safety for themselves. However, healthy relationships and interactions were not modeled for them in these environments. So they don't necessarily know how to set goals or achieve or manage structure in their day-to-day life. And so while that may seem a little outside of the PT scope, what this allows me to do is recognize when an individual is really concerned that they're disappointing me, providing appropriate reassurance, and then making sure I am not just asking them to select goals, but guiding them in healthy processes as far as setting and achieving goals. We may be the healthiest adult relationship in this individual's life, even if the trauma happened decades ago. And then the last two, they'll often have difficulty with emotional regulation or heightened sensitivity to stress. And while counseling is very supportive in this area, I want to argue that we teach graded exposure and stress management very regularly in the physical therapy practice. So again, we have an opportunity. The word in the studies for ACEs is called reparenting, where we have the opportunity to come in and reparent and gently guide this individual who did not grow up in a supportive environment. When we look at physical behaviors that you might see associated with trauma, I often see these in the subjective exam for patients. These are considered adaptive to help regulate the individual. So stemming, most of us will see fidget spinners or they're clicking their pen quite a bit. If I see a patient stemming quite a bit during a subjective exam, I will hand them a fidget spinner, or many of us have those biomechanical models in the clinic. A lot of my stemming patients love pulling them apart and putting them back together like a puzzle whenever they're doing the subjective exam. This helps them regulate. When we look at freezing, most of us are familiar with fight and flight. There are two others, freeze and fawn. Fawn is that people-pleasing behavior we saw on the last slide, where that individual is trying to please you in order to earn safety. Freezing is when the nervous system is perceiving a threat and chooses to help this patient shut down in response to that threat. So, a lot of times with these patients, I will see them having difficulty initiating a movement or an activity. This is a great cue for me to break that activity down into smaller steps and teach them how to achieve them. When we look at self-soothing touch, these are patients that are constantly rubbing their hands together or rubbing the tops of their thighs. This is often a patient who responds very well to manual therapy with appropriate consent for touch, or even their own manual therapy interventions. These presentations are more common in cases of trauma. When we move into our objective exam, some of the things I very commonly see in these patients is chronic vestibular disorders, so chronic difficulty with dizziness and vision. Motor control is huge. If we think about this for just a moment, when trauma occurs, we will see an adaptation in the nervous system. That nervous system then may lack the coordination to do functional tasks or things this individual had done before efficiently. So I really have learned to enjoy incorporating motor control when I have a patient who I have a suspicion of trauma to help that adaptive nervous system regain certain movement patterns. We also see sensory processing disorder, and then there are several characteristics we may see in individuals who have past medical histories of trauma, but perfectionism and frequent apologizing is something that I often see with these patients. So I want you to think about this patient that we see in practice where we teach them a completely novel exercise. They've never done it before in their life. And they can't stop apologizing because they keep messing it up and they're worried you're going to get upset at them. And they hold themselves to this ridiculously high standard of being able to get it perfect the first time. If you would like to learn a little bit more about how mental health and the mind plays a role in movement and how you might see that during an exam, I want to direct you back to Lunch Bites webinar number 3, where Tabitha talked about how we might see that clinically in practice. That's going to give you a little bit of more depth. But I want to end this section with a disclaimer. Just because we see these behaviors does not mean this individual has a past medical history of trauma. However, research is showing a meaningful enough overlap. This should cause us to pump our brakes and look for additional data that may support this so we can appropriately adapt our care so the patient does not have to adapt to us. Now, if your patients are like my patients, they don't get to the end of the exam where I've collected all this data before they share their trauma. And I am thankful for that. But I think one of the challenging things with this is when I was initially trained in trauma-informed care, I was taught the phrase, thank you for sharing, and gentle redirection back to something that I needed to talk about to keep me in scope. And what I often found was this created a little bit of a disjointed change in topic, and I often felt I was dismissing the person in front of me from what they'd shared. But if I tried to continue the conversation, it often moved out of my scope. So I have found these next 3 questions really helpful in keeping me in scope and helping me understand my role. So if the individual shares that they have had childhood trauma in the past or past trauma, my probing question is, did you get the support you needed at the time? This tells me whether or not they received counseling, whether they had supportive adults in their life, whether they were removed from the situation as a child. I get a really good idea of, did this nervous system adapt? And has it remained adapted because they did not receive the support they needed at the time as perceived by the patient? This is an opportunity for me to know, in these cases, when they did not receive support, my plan of care may need to be a little bit longer. because they're going to have nervous system deficits that will require additional time and patience, and then a lot of the graded exposure I was talking about earlier. When we look at the next question, if someone is talking about their trauma affecting them right now, I want to ask if they have the support they need right now. This often segues beautifully into the patient sharing whether or not they have a counselor, a supportive partner, a faith-based support system. They're able to share with me what resources they have, and this lends the opportunity for me to gently redirect to resources I can help them get to, but I begin to understand where I am on their team at that point. And then the last question is the most supportive. What support do you need from me? I want to normalize, again, that trauma does not equal fragility. And the fact that someone shares a past medical history of trauma with us does not mean that they want us to rescue them or save them in any way. Oftentimes, it means they have built adaptations that they would like respected in a plan of care. And they need the opportunity to share that with me so that when they ask for specific things, I understand why they're asking for it without them having to rehash their trauma each time. This is also an opportunity for me if someone is venturing out of my scope to redirect and provide resources. But generally, what happens is I get a really good idea of what this human in front of me needs to move forward in their healing. And then once I have that role, I can start what I call a capacity assessment. I can assess their barriers to care and then begin trauma specific interventions. So I want to introduce the load capacity model to you. This is something that I use, and it is a simplified version of what we do in trauma informed care, but it does help direct me when I am struggling to work with a patient who is struggling with this. So the A represents the load. This is the bell curve underneath the dash line. This is anything that this individual is carrying on a day-to-day basis, and that is patient specific. Understanding what work demands they have, familial demands, whether they have pain or sleep disruption. Any of this helps point me in the right direction as far as, what load is on this individual's shoulders when they come into a clinic to see me. Next is capacity. I have certainly met individuals carrying a ridiculous load and carrying it beautifully because their capacity exceeds their load. So this is nervous system bandwidth. This is where physical conditioning falls into place, their resilience, their support system. This capacity allows them to carry a specific size load. But what I want to notice here is that this list or this overload list is often what we spend a lot of time managing in the clinic. And I would even argue this is what some of us struggle with in the clinic when we are working with patients who have a past medical history of trauma. And while certain things like suicidal ideation require prompt and immediate care, if we are only working on overload in our trauma patients, they will often fail to move forward. So when I am working with a trauma patient, while we certainly manage overload, I am looking for my opportunity to try to influence A or B. So the question I ask myself is, what capacity does this person have today? Do they have enough capacity that I can put a physical load on them, even an emotional load, or begin to try to do graded exposure into challenging tasks to try to build their capacity for the load that they're carrying? Or is their load starting to exceed that capacity? And is there something I can do to intervene to reduce load so that it stays below that line? What I want to encourage you with is that the things that we do on a day-to-day basis already have evidence supporting that they help patients with mental health issues. So manual therapy, pain neuroscience education, and physical activity all have evidence that they decrease load and increase capacity. Just doing our jobs and doing it well can help support our trauma patients in healing. But what I will say most of us probably struggle with is when I am trying to use these items to manage mental health conditions, how do I bill for that? So for the sake of time, I am going to actually redirect you back to Lunch Bites webinar number 2, where Matt and Ellen did a beautiful job talking about our role in mental health with patients and how we can bill for mental health services and support. Let's talk a little bit more about what we can do from a trauma-informed intervention to help them a bit better. So this is one of my favorite clinical practice guidelines. It is not a PT clinical practice guideline. It is the Veterans Affairs and Department of Defense clinical practice guideline for PTSD. So this is the guideline that they utilize when individual experiences trauma, and they're going to try to either reduce the intensity of PTSD or try to prevent it from occurring. And the very first thing they do is this box of sidebar immediate needs. And I want you to notice that they try to establish safety, food, hydration, sleep, orient them to the situation, connection with people that are close to them, and education where we normalize their response to what just happened. I want you to notice the beautiful overlap we have in the CPG with lifestyle medicine. And that brings us to challenge number 2. Are we regularly screening lifestyle medicine in practice with our patients? Because I will say, working with trauma, I have learned that lifestyle medicine is an irreplaceable tool in helping reduce load and increase capacity for my patients, but I have to be asking or delivering appropriate outcome measures. I think a limitation I know I struggled with early with the use of this tool was patients struggling with behavior change. So I want to redirect you to Lunch Bites webinar number 4, where Kelly talked about assessing people's stage of change and then how to encourage them in selecting specific goals to create behavior change. And I think that can really help as we're implementing lifestyle medicine. As we round out to the end of this presentation, I want to briefly go over a few nuanced things when we look at the 6 pillars of trauma-informed care. When I first read safety, I thought physical safety, and that is absolutely true. But a lot of these patients with their adaptations are really struggling to integrate into society and even into work and familial roles. And safety often means the ability to come exactly as you are to a PT appointment and be accepted and safe there. When we look at trust, the key thing I want to point out here is we do a beautiful job, and we should, trying to get a patient to trust us. Sometimes our role is to trust the patient. Their nervous system has adapted, and only they are the expert in their experience. So sometimes I need to trust them when they feel an intervention or an approach is going to be more supportive for them. And then the collaboration means my healthy curiosity to understand how their nervous system has adapted so I can support them. The other thing I want to highlight is I think it's so important that we're offering choices in these cases, but for many of our trauma patients, choices in the past have come with heavy negative consequences. So they may not have the self-efficacy to make choices. And part of our role in trauma-informed care is to teach that self-efficacy and to teach and empower the patient to advocate for themselves and for their nervous system adaptations so they can receive the care that they need. That means coming beside them as a coach versus an expert and giving them our confidence and our skill level in navigating the medical system where they need support. And then lastly, we can't forget about cultural, historical, and gender issues. Our evidence says that we, just looking at medicine alone, are still struggling to deliver consistent, uniform care. And that makes individuals who fall into these categories more likely to experience trauma in the medical field, let alone everywhere else. With that in mind, though, as we are in this setting, it can be incredibly challenging to hear about their trauma and their life experiences, and to struggle with the fact that we are held accountable for the error of someone else. And while that's important and part of our job for healing, I want to encourage you to consider something Lisa shared with us at Lunch Bites webinar number 1. At the very end, Lisa talked about the importance of self-care when we are working with mental health patients or we are working with patients who have experienced trauma. We can experience secondary trauma. So the traumatic event that's shared with us traumatizes us from hearing these stories and walking with these patients. All of the lifestyle medicine interventions, all of the interventions that I have shared up to this point are a two-way street. We need to be managing our own load and our own capacity and doing appropriate interventions for ourselves so we are whole healthcare providers when taking care of our patients. So, in closing, where do we start tomorrow? I'm going to review some of the challenges we just did. So, challenge number 1, start screening for yellow flags consistently. My favorite phrase with this is standardization decreases stigma. If everybody's getting it, it becomes less of an issue. Challenge number 2, when we think of screening for lifestyle medicine, we may be tempted to overcommit and do an outcome measure. If that seems overwhelming, just begin asking your patients what they ate for breakfast that morning before coming to PT, or if they slept well the night before. Let's begin to assess load and capacity before we start adding additional load to a system. And then last and most importantly, please apply trauma-informed care to yourself. These patients need you, they need healers, they need people that support them. We need you. And in order for that to happen, in order for you to be a whole, healthy provider, you also have to make yourself and your self-care a priority. I want to thank you for your attention today. This QR code will take you to the handout where all of the references are listed. I have YouTube links to the previous webinars and a few other resources for things that I think might be supportive. And then my contact information is here. I would love to go into questions now.
Thank you, Faith, for those insightful and practical points, and also for connecting today's discussion with our previous lunch bites as well. We try to curate the lunch bites so that they um, complement each other. So we have a few minutes for questions. If you have any, please place them in the Q&A box, and we'll do our best to address them. So far, we don't have any questions, but what I like about the presentations is that the load capacity visualization. Um, it's great to like explain how people like our patients are adapting and are coping all with their day-to-day stresses and what they experience from the past to how it affects them now.
Thank you. Common screening tools that I use in the clinic.
Mhm.
Absolutely. So I use the Promise anxiety and depression 4-item scales. So those are easy for me to screen for anxiety and depression. I use the Orabro 10-item questionnaire to help me predict chronicity, but then it also helps cue pain catastrophizing and Tampa scale of kinesiophobia. For my lifestyle medicine, I actually included in the handout. It is an Excel spreadsheet that I utilize that creates a colorful wheel that makes it really easy to set goals and understand what pillars the patient may be struggling with. It's a 21 questionnaire, 21 item questionnaire. I use that if I feel like lifestyle medicine is influencing it, but the prominent outcome measures I utilize are the Promise outcome measures just for efficiency.
So we also have a couple of questions that came in. Is there a specific professional course for trauma-informed care for PTs that you can recommend?
So I don't have a specific one. I know that there are definitely more available now than there was when I started practicing. I think my best recommendation, I have several. My best recommendation is one, our best teachers are our patients. And so if you have access to books written by trauma patients where you learn about their healing journey and what they went through, they'll often talk about counseling and their experiences in the medical field. I will say those have dramatically transformed my practice more than any course ever did because they talk about the people who helped them and the people who were not able to help them. I would also encourage you to look into the literature. There is a lot more studies, and I have included some in this presentation that talk about trauma-informed care in PT. Many of them are authored by individuals who own companies where they offer specific training. So if you find a study that you feels really aligns with your practice, I would recommend that you look at those individuals and see if they have an additional course. But those would be my top two recommendations as far as both understanding the patient side and then finding some training that's supportive for you. Great question.
Yeah, just have one more question. Do you see insurance and productivity barriers commonly encountered by PT professionals in their practice?
I think that's a great question. So, when we consider, without driving too much into the billing, when we consider operating within our scope, we are still billing as we typically would for standard PT interventions. And I know Matt and Ellen did a lovely job covering that in their presentation to understand the productivity side of it. The challenge I see here is in practices where you might have two or three patients in together, and it might be a little bit harder to kind of sit down with one person. I think that's where those three screening questions that I provided earlier can be helpful. I never want to interrupt someone when they're sharing something that's sensitive with me, but I often find I can use those questions to just compassionately stop them and redirect them if I need to come back to my scope. If if we're struggling to stay on track as far as you know, using our time efficiently in the physical therapy clinic.
Yeah.
My encouragement would definitely be, though, to consider that webinar with Matt and Ellen. It was helpful.
Cindy clarified the question. She also meant barriers in incorporating trauma-informed care in her practice. Were there any barriers that you encountered in incorporating trauma-informed care principles?
To be honest, I think it unlocked a potential for my practice that I was not expecting. I think the biggest barriers that we find is we're very concerned about our scope, and we should be. Absolutely. This is our license. But I think what I neglected to understand was that I'm trained in the nervous system as much as I am, muscles and bones and joints. And so understanding how trauma influences the biological system can help us understand why this is within our scope. And then initially it can be very upsetting at times when patients share specific stories. So I'm going to go back to the self-care recommendation with this. I have a counselor. I don't necessarily see her year round, but I check in with her like she's my PCP every 6 months. And I tell her the major events that are going on in my life and how I'm coping with them. And like a PCP, she can tell me we need to manage it more or I'm coping well. So having regular mental health support for you in case you need to process something. And then within my company, I actually have resources. If I am struggling mentally with something, my manager can support me in getting direct care for that. So that would be the biggest barriers I perceived and the way I've been able to overcome them. Fantastic question.
I think
Oh,
that's
and
all the time that we have. There are some suggestions of
yes,
books
absolutely.
in the comments. I think that's all the time that we have. Thank you so much, Faith, for sharing your time, expertise, and practical insights for us today. That is all for our lunch bite. And as a reminder, today's session was recorded and will be posted later on at the APTA Academy of Leadership and Innovation YouTube channel. And you'll receive a brief follow-up email tomorrow with a link to our short evaluation survey. We really appreciate your feedback. Next month, we'll continue with a conversation with another lunch bite focus on motivational interviewing. So, thank you again, everyone, for being here, and we hope to see you again for the next lunch bite. Thank
Thanks,
you.
everyone.